Hello, everyone. Welcome to join this PSCVIR outreach program Embolization Part 2. Today, we have many interesting lectures and excellent speakers. Our first speaker will be Dr. Brandon Buckley. Dr. Brandon Buckley has been a specialist in IR at Auckland City Hospital since 2004 and clinical director since 2020. His areas of interest include solid organ ablation, vascular anomalies, and embolization. He is the lead clinical IR for the regional vascular anomalies, multidisciplinary team, the renal ablation program, and the uterine and prostate artery embolization programs. He is the secretary for the Interventional Radiology Society of Australasia. So, without any delay, please welcome Dr. Buckley. The topic of his presentation is varicocele and ovarian vein embolization. Dr. Buckley, please.
Thanks very much indeed, Rick, and thanks very much to PSCVIR for asking me to join this fantastic series for embolization. And in the interest of time, I'll press on, and my topic is varicocele embolization and ovarian vein embolization. You'll have noticed I put ovarian vein embolization in inverted commas, and I'll come back to that in the latter part of the talk. So the first part of the talk, pretty straightforward. Varicocele embolization, we're all very familiar with this, a very common condition. The incidence, depending on the paper you read, anywhere up to a quarter of the population, and associated with infertility, and certainly more increasingly so over the last decade. It's been seen as an important part of infertility. The vast majority of varicoceles, as we know, are on the left side, and the minority, in fact, in our experience, probably less than 10% on the right side, and then a certain incidence of bilateral varicoceles, again, not very well documented in the literature. These days, and I think it's something that's changed in my clinical practice over the last decade, is that the majority are asymptomatic. And we're noticing that most of our patients who are referred for varicocele embolization now are related to fertility, and I'll go into that in a little bit more detail. For patients who are symptomatic, we recognize those symptoms very well. Dull ache, typical venous symptoms, dull ache at the end of the day, exacerbated when you cause dilatation of veins, so hot weather, exertion, and relieved when lying flat, so all the kind of plumbing around veins that we'd expect. There's lots of grading systems, and both clinical and ultrasound. In fact, most of the time now I grade my varicoceles with ultrasound. And the importance of that is that I do it while standing. What we're talking about with all these venous pathologies is we're talking about a physiological as opposed to anatomical pathology. We're talking about how these veins are functioning, and that changes from the time of day to the degree of hydration to the type of exertion. So we do our Doppler ultrasounds with patients standing, and we assess them with Valsalva while they're standing, and we assess real-time reflux into the veins, as you can see in the top right-hand corner, and looking for dilated veins. And obviously very important to exclude renal or abdominal pathology, especially in older patients, as a cause for an obstructed spermatic vein. So you'd always need to examine the kidney to make sure there's not a tumor causing that. So the indications for treatment, obviously symptomatic varicoceles, and early on in my career, these were the majority of cases that we treated. But now, as I said, subfertility and in adolescence, testicular asymmetry are more common causes for treatment. And that's really on the background of a significant increase in the literature supporting the outcomes for varicocele embolization in patients who have infertility or male infertility. In fact, there's good data to show that as one of the most cost-effective measures in male infertility, varicocele embolization should be considered early in the fertility journey. And in adolescents, as we know, they can be associated, there's good evidence to show they can be associated with testicular atrophy, and certainly shown to be associated with impaired spermatogenesis. And really one of the important aspects of that is sperm DNA damage. And the more recent literature supports this significant impact on sperm DNA quality with treatment of varicoceles. And it is the commonest identifiable cause of male infertility. So why embolization when there's a strong background of varicocele surgery by urologists? Well, it's a shorter operating time, significantly quicker recovery. We avoid a lot of those surgical complications, hematomas, hydrocele. And while it's a low complication, and with good surgical technique, probably 1% or less, there's no risk of causing arterial injury with endovascular embolization. And the recurrence rates with a very good quality treatment is very similar to surgery, and a similar improvement in semen quality. So really all the things that we'd expect of interventional radiology. Now, in terms of the approach, it really does vary very widely by centers. So what I'll go on to talk about is my individual approach, and I fully accept that there's lots of different ways to skin this cat. And so what I will talk about is not necessarily stating this is the best or main way to treat a varicocele, but it's certainly the way we do it in our center. So as you'll know, wide a number of approaches. Common femoral vein, historically the most common approach, probably not so much now. Internal jugular vein, certainly in our center, is by far and away the most common approach. In Italy, I know brachial vein and arm vein approach is very common. And then in rare occasions, we will use an antegrade approach, a direct spermatic vein approach, and I'll talk about that a little bit later. Again, you can get quite animated debates around the embolic agent that people choose. Coils, again, traditionally the most common. Foam sclerotherapy, I would say increasingly used, and certainly in our center. I think the lower three have been tried and published, but I wouldn't see those as being embolic agents that we would consider appropriate for varicocele embolization. This seems like a little bit of a side branch or side discussion, but I do think it's relevant in my and our center's selection of the embolic agent that we choose. And this is a recent statement by multiple vascular and phlebology colleges with regard to greater saphenous vein occlusion. And they're quite clear to say that there's no high quality evidence to support physical embolic agent. And it's really interesting because clearly there's an awful lot more peripheral or axial vein embolization done than there is spermatic vein embolization done. So there's far greater quantity and quality of data related to that. And it's interesting to note that it would be an anathema to use a coil in a peripheral vein, but we're not treating an entirely dissimilar venous pathology with both varicocele and ovarian vein pathology. So just to support our approach is that we know that occlusion of veins with sclerotherapy is really well established with excellent outcomes across a wide range of venous territories. And so that's why we choose primarily sclerotherapy as our agent of choice. We also choose the right internal jugular vein because we think it's much easier access, and certainly our success rate of right spermatic vein access is significantly higher with the jugular vein approach compared to a femoral approach. And I'm not saying that it's incorrect to do a femoral vein. Many interventional radiologists will be very successful with a femoral vein approach. We use a 5 French MPA catheter. We also use a fem stop on the inguinal canal, and I'll talk about that a little bit later. And there's lots of different recipes for sclerotherapy agents. We use a one that I find easy to remember. I make it simple for myself. So we use 3% sodium tetradecyl sulfate and lipiodol foamed with air, and we use an equal allocation of each. So we use 2 mils of 3% fibrovane, 2 mils lipiodol, and we foam that using the Tessari technique with 2 mils air. So very straightforward. And so this is what you'd expect to see, as I'm sure many of you have. with our 5 French MPA catheter from a jugular approach in real time, showing gross reflux down that spermatic vein. And we'll put our MPA catheter to the distal third of the spermatic vein. And the reason we put that femstop on, that's the femstop you can see before it's inflated over the spermatic vein, is because we want to inhibit reflux into the pampiniform plexus. We know the pampiniform plexus will close if we successfully occlude the spermatic vein. We don't need to cause a significant phlebitis in the pampiniform plexus, because that has both symptomatic issues for the patient, but also maybe some concerns about collateral non-target injury to the pampiniform plexus draining through the vas deferens, and also the posterior drains draining to the via the pudendal vein. So we use a femstop just to trap that foam between the inguinal canal and the renal vein. And so here you can see on the right-hand side, what we do is we slow it with the patient in a reverse Trendelenburg and the femstop at about 50 or 60 millimeters mercury. You can vary that a little bit. We slowly withdraw the catheter, as you can see on the right, slowly laying out the sodium tetradecyl sulfate, and we can stop and we can twist the catheter to cause a little bit of venous spasm, because we want to do that, because what we're looking for here is dwell time and a good injury to that vein by the sodium tetradecyl sulfate to cause occlusion. Right varicocele, again, we engage the right renal vein, we come out of that, we turn the catheter anteriorly, we trail the catheter along the anterior lateral wall of the IVC, and that's shown here with the catheter going into the IVC and then just slowly popping into that renal vein, and then we can see that there's the spermatic vein, there. And again, what we'll do is we'll show reflux. You can see the femstop at the lower part there, and then laying out that sodium tetradecyl sulfate with the femstop in position, with a nice column of sodium tetradecyl sulfate seen on the right image, and nicely filling the vein. You can see at the end it's quite a big vein, and that's probably the size of the vein during the normal working day, or during the normal day being upright. So the outcomes are very good, and I think that's probably whichever method you use, 90 to 95% success rate, very low complication rate. Venous perforation, it happens. It's often not a real problem, certainly not causing any significant issues, even with sclerotherapy going outside the vein. The thing I do warn my patients about is scrotal discomfort or testicular phlebitis, which is kind of the technical term of this phlebitis in the vein. It responds very well to simple analgesia, ibuprofen, paracetamol, but it's important to warn patients because it's the one thing they'll ring you up about and say, listen, are you sure you haven't done anything wrong here? And we can be confident we haven't, but we know that this occurs in about 5% of patients. Hydrocele has been reported. I haven't seen in our series, quite a large series, but it has been documented in the literature. I do tell patients that there's a rate of failing to selectively catheterize the spermatic vein, probably less than 5%, I would hope, although in the literature reported in up to 30%. But clearly disappointing for the patient who's been on the table if they weren't aware of that beforehand. So I do think you need to discuss that with them, even though it's very unlikely. Retrograde, very briefly, spermatic anatomy can be very varied, and sometimes it can just be very difficult to get into the spermatic vein. And so on those occasions, we can do a retrograde direct approach. It's been described surgically, but in actual fact, we use a micropuncture set, a 4 French glide sheath. And here's an example here where it's a 21G micropuncture needle into the spermatic vein. This is a previously treated surgical ligation, which you can see has failed. And we've been able to get into this retrogradely and put sclerotherapy there. I do warn patients that it's probably more likely to get a testicular phlebitis because it's more difficult to control the sclerotherapy going into the pampiniform plexus. So sorry, that's a bit of a whistle-stop tour, but I think for testicular embolization, very effective treatment, very cost-effective, especially in male infertility. There's lots of individual techniques that can provide the same outcomes, and we can use retrograde access if we need to. Now I'm going to go on to ovarian vein embolization. I'm going to try not to run over too much. I put this in inverted commas because it's not the same as varicocele embolization. I really need to stress that. There's much more complex clinical assessment, more challenging to determine the endpoint, and actually more difficult to assess outcome. And obviously this is related to this normally termed pelvic congestion syndrome, which is not a very well placed terminology because it doesn't really characterize gonadal and pelvic vein pathology properly. And that's defined as chronic pain not related to the menstrual cycle for over 6 months. It increases in incidence with the number of pregnancies, so it does vary around the world. And so obviously within your own country, if you have high family, big family sizes, this is likely to be a higher condition. And in a lot of Western countries with family sizes dropping off, it's a less common condition. Typically presents obviously around that childbearing age and with increased gravida. And it's presumed secondary to this chronic hypertension in the pelvis, causing distension of the veins, releasing these substances that cause inflammation. And that inflammation is what's leading to this chronic pain. I'm not going to go through these, but this is one of the challenges around ovarian vein embolization and pelvic vein embolization. It can present in a myriad of ways because these inflammatory factors can stimulate a lot of areas in the pelvis and all the other pelvic organs. And it's also very difficult to assess. Ovarian dilatation is seen in up to 10% of in women on CT, and the diameter doesn't correlate with ovarian reflux. And we know that in greater saphenous veins. So we know that patients can have big greater saphenous veins that are competent, but we know that patients can have smaller greater saphenous veins that are incompetent. And the very same is true of ovarian veins. You can have smaller veins, that's 3 to 5 millimeters, that are incompetent with reflux, and you can have larger veins up to 8 millimeters that are actually competent. So it's a difficult area to assess. They do have valves, but more commonly they're absent in the left compared to the right vein. And we have to remember that the venous plexus around the uterus and the bladder and the vagina and rectum is valveless. So there's free flow of venous flow around all those organs. Really important to remember when deciding to treat these. Also important is that the right ovarian vein, which is more often competent, can serve as a shunt for gross left ovarian vein and pelvic incompetence. So it's important to define that, because if you embolize the right ovarian vein when it's serving that function, you can cause symptoms to deteriorate. And here we are in this conundrum of how do we assess this complex problem? How do we image it? Well, MR is probably one of the best non-invasive imaging, but even with that, the specificity and sensitivity is not particularly great. Laparoscopy reported as 40%. I'm dubious of that, but now many gynecologists are doing laparoscopy without CO2 insufflation before they look into pelvis to improve their chance of seeing the veins. Ultrasound, I think, has improved over the years, so I would rate it as slightly higher than that kind of published literature. CT is often used to identify this, but in fact, the sensitivity and specificity is quite low. And as we know, real-time imaging of veins is best done with a catheter inside the veins. And so I put this up because I think our sonographers are getting much better at identifying venous incompetence, both in the ovarian and pelvic veins. And so we get these really nice, documented, dilated, incompetent veins that we can make good decisions on. So I would say a lot of our practice has gone towards vascular sonographers identifying this, rather than going for CT or MR. But that said, MR is very good at showing in real time, especially if you do time resolved. We can see this real time shunting down the left ovarian vein. I haven't put in one case we have, which is a lovely real time example of shunting down the left and up the right. So it's something that you've really got to be aware of. Here's a CT we can see with these dilated opacifying veins around the pelvis, clearly not normal in this large left ovarian vein coming down into that left ovarian plexus. These are dynamic views. I'll probably skip over them because we're running out of time. So what I put up here is probably the easiest cohort of patients to decide to treat is what I would call obvious pelvic incompetence. And that's patients who have associated lower extremity venous incompetence, posterior thigh, vulval, perineal, often associated with significant pelvic pain. And we can see here in this MR, there's these myriad of veins around the perineum, all through the thigh. And we can see this in grossly, actually this one, sorry, wasn't associated with ovarian vein incompetence. We can see the left ovarian vein is actually kind of patent, but certainly when we went into the pelvis, we saw gross pelvic incompetence. So here's this patient with a catheter in the internal iliac vein, Valsalva, and you can see she's dumping all these veins directly into the perineum. And so we went on to treat that. And we can see we use a combination of coil, but mostly sclerotherapy. And we're using sclerotherapy with direct stick to the vulval varices, and also through the catheters in our internal iliac vein, going through that large incompetent pudendal vein. So these can be complex to treat, and you often have to come at them from many different angles. And what we can see is that on the completion MR, there's a resolution of quite a bit of the veins that were in and around the pelvis prior to embolization. So again, my approach, and I'm not saying this is the best or the most successful approach, but it's my approach. We find the right internal jugular vein technically easier to get in both ovarian and pelvic veins. We use a 5 French MPA catheter. We sometimes use balloon occlusion of the upper aspect of the ovarian vein, and we'll sometimes use coil and amplets to control control assisted sclerotherapy. And we use the very same sclerotherapy recipe that we use for varicocele. So again, we recognize this from varicocele, but it's not the same. As I said, you've got to be far more diligent in assessing this, but we'll use our 5 French MPA catheter, and we'll go into the ovarian vein and we'll see that incompetence. And that's when we can go down and very quickly. This is one where I've used both. On the right-hand screen, you can see a coil assisted, and here we're delivering an Amplatzer plug. And why do I use this? Because I don't want to flood the pelvic venous plexus with sclerotherapy. What I'm doing here is similar to, or analogous to, I'm filling up this vein with Lipiodol and sodium tetradecyl. And you can see it sits there very nicely. I think the Lipiodol causes a little bit of venous spasm. You can see it sits in that perivenous vascular plexus, but it doesn't flood it. So I don't get a massive phlebitis in the pelvis. So I find that useful as a kind of coil assisted. And as you can see, I'm laying out the sodium tetradecyl in this left ovarian vein, and it's filling the vein very nicely. It's staying where it is because of our coil assisted protection here, and it's not flowing out the top of the ovarian vein. And another example of coil assisted protected sclerotherapy of that ovarian vein. So we're trying to avoid flooding that pelvic venous plexus. Complications also very rare if you're careful. Vein perforation, again, usually not a significant issue. Migration of embolic material, I think that's more of a worry with coils than it is with sclerotherapy. Ovarian and pelvic vein thrombophlebitis, really important to tell your patients about this. About 5% of them get an increase in pain. It's very disappointing for them, but again, it runs a classical course of 1 to 2 weeks and responds to simple analgesia. Radiation exposure to ovaries, I think we need to be careful or aware of that in young patients. And I've had quite a number of patients describe a change in the characteristic of their menstruation, not necessarily heavier, but just different. And so I warn patients about that now. This is just an example of that right side being orthograde with Valsalva with rapid orthograde flow. So that's not a vein to embolize because it's probably serving as a useful shunt for the pelvic venous incompetence. So in summary, ovarian vein embolization, clinically and technically more complex than varicocele embolization. It really needs careful clinical assessment, and you have to do prudent pelvic vein embolization and the clinical outcomes carefully discussed with the patient, because we know that probably about 75% of our patients will get a good response, but there's not an insignificant number who don't notice a great change. So sorry, I've run over a little bit there, but quite a bit to cover. Thanks very much.
Thank you very much, Dr. Buckley. Is there any question from the panelists, from the audience? Any question about, maybe let me start by asking you a question. Or do you always do bilateral ovarian ring embolization in pelvic congestion syndrome? Always bilateral embolization?
No, I interrogate both ovarian veins, but I find that in a significant number, I don't embolize the right. And that's because in real-time venography, there's orthograde flow, and that's an important outflow for the pelvis.
That means most of the time you only embolize one side of the ovarian ring, is it?
Not most of the time, but I would say I would say the majority, we end up in significant cases of reflux, we embolize both. But the decision to embolize the right more frequently than the left is a real-time decision based on the flow and in that vein. And so I would say maybe in a quarter of patients, we're not embolizing the right because we've demonstrated it's a functional vein.
Okay, thank you. There's a question from the audience. Do patients experience intraprocedural pain with variable vein injection?
Yes, absolutely. Great question. They can. And we do all our cases under pseudoanalgesia with fentanyl and midazolam. They're clearly all day case. They're usually home after 2 hours. But we find that with a combination of fentanyl and midazolam, most patients tolerate it extremely well.
Okay. In your presentation, it seems that you use sclerosant in most of your cases doing ovarian embolization and also varicose embolization. Is there any, how should we prevent the migration of the sclerosant causing pulmonary embolism?
Yeah, good question. In actual fact, the risk of that is very low. So when you think of the volumes we're using maybe 4 mils of sclerosant. As you saw with my examples, the Lipiodol stabilizes the foam, so it keeps it in the vein. There will be a leak of a very small amount. The dilution from the very high venous flow in the renal vein doesn't really allow it to cause any injury, and certainly doesn't result in a pulmonary embolism. So if at most 0.5 of a mil escapes, it's not a significant volume, and that's well documented. In actual fact, for many of us involved in vascular malformations with sclerotherapy and venous malformations, there's a far higher volume and a far higher migration. So giving it context, I do not quote my patients a risk of non-target embolization into the lungs.
There's another question from the audience. When do you choose to embolize the pelvic varices in addition to the left ovarian vein embolization?
Perfect, great question. I think that's the critical question. I'm slightly conservative. I interrogate both of the internal iliac veins, and if you saw the example where we saw gross reflux, easy, embolize those straight away. For the majority of cases, I stage it. I embolize the ovarian vein or both veins first. I reassess the patient in clinic, and then if they've still got symptoms, I interrogate the internal iliac veins again, having done it the first time round, and then consider embolization. Very quickly, a cautionary tale from Stephen Black in London. He's done a number of operations with large volume coil embolization of the pelvis, causing migration of coils outside the veins and pelvic inflammatory and fibrosis. So we've got to be a little bit careful about how aggressive. I'm not saying coils aren't right. We like foam. Coils also work well, but you've just got to be very prudent about how you embolize the pelvic veins and not be overly aggressive.
Hi, thanks, Brendan. Kang Hyong here. I think thanks for a very nice talk. In the interest of time, I think we better move on.
Yes.
Yeah, we have quite a few talks.
Yeah. Sorry, apologies.
No. Don't be apologetic. Okay, my name is Kang Hyong Tae. I'm IR from Singapore General Hospital. I'm co-chairing the session with Ricky from Hong Kong. Our next speaker is also from Hong Kong. It's Professor Simon Yu, which really needs no introduction. Professor Yu is a very distinguished IR, not just in Hong Kong, but around the world. He's a very prolific academic and has close to 300 publications and have probably close to $10 million worth of grants and numerous patents. He was awarded the first class award for outstanding research output by China's Ministry of Higher Education. Professor Yu is currently a professor of imaging and interventional radiology at the Chinese University of Hong Kong. And today he will be speaking to us on prostate artery embolization. Professor Yu, please.
Good afternoon, everyone. It is my pleasure to talk on prostate artery embolization. So the goal of PAE is to achieve ischemic necrosis of the prostate tissue. The particles that we use for embolization is a microsphere in the range of 0.1 to 0.3 millimeter in diameter. There is no evidence showing any correlation between the size of particle and the clinical outcome within this range. So histology slide shows the particles within the prostate, and MRI shows the degree of infarction very nicely. The darkened area represents the infarction, and typically a significant reduction of prostate size can be achieved within 3 months, in this case 60%. So we offer PAE because it is minimally invasive, which is good for the patient, minimal morbidity, and the patient can be reassured of a very rapid recovery. And most importantly, it works. So we subject the patient to a number of tests in order to exclude possibility of cancer and bladder dysfunction, urethral stricture, etc. So we don't want to treat patients who are too young or prostate too small, symptoms too mild, and acute urinary retention and hematuria are also good indications for PAE in cases of BPH. So it's been shown that PAE is very effective to relieve complete urinary outflow obstruction due to BPH. And how about the long-term outcome? We have followed our patients up to 3 years. We can see very persistent in the good outcome. Although about 10% of them do not respond well, that could be due to other factors, which we'll come to now. There are factors which is known to associate with poor outcome. And there are factors we know there is no association at all. But we are not going to exclude these patients because of the unfavorable factors, with the exception of this one. So in these cases of intravesical prosthetic protrusion with a thickness to height ratio of less than 1.3, we know that these are associated with complications and adverse effects. So we put that as a contraindications now, in addition to vascular occlusion or infection or coagulation defects. So by TH ratio less than 1.3, we try to identify those tubular shape of IPP within the bladder. We know after embolization, this should become necrotic and become very soft, and because of the bicuspid valve effect, it would lead to worsening of the obstruction. So before procedure, we counsel our patients, let them know what to expect about the recovery, about the morbidity, and the long-term outcome, the recurrence rate, and also to exclude other possibilities other than BPH. So we have to let them very sure about what to expect and what are the possible complications. So before the procedure, we prepare the patient with pre-medications such as Voteran for pain relief, and Dalcorex to remove the rectal shadow, prophylactic antibiotic 1 day before, prevent infection. And we avoid the Foley catheterization because we want to prevent referral complications. And we know that there are a number of variations as to the origin of the inferior vesical artery, which gives rise to the prostate artery. We need to know them. And we know that the majority of the prostate artery are solitary artery on each side. And this is a typical oblique view of a pelvic arteriogram and showing the origin of the inferior vesical artery, which is over here. So this is the inferior gluteal, internal pudendal artery, and this is a common trunk of superior and inferior vesical artery, and this is inferior vesical artery, and this is the prostate artery. So we will select up to the point of the border of the prostate to bypass all other branches, so as to avoid non-target embolization as much as possible. So we take each procedure very seriously, and with that, we know that these procedures are associated with only mild and transient adverse effects, relatively safe. Major complications are rare, provided we do it properly. So these are procedure tips. First of all, we use a guiding catheter, and that will support the microcatheter well. That will facilitate advancement of the microcatheter. Use of guiding catheter, there are a number of choices for different approach, femoral approach or radial approach. For right, inferior vesical artery or left, there are different choices. So in this case, we can see that the inferior vesical artery is over here, and the guiding catheter is over there. There's still a gap between them. So in this case, we will try to advance the guiding catheter up to here before we do the catheterization. That will facilitate the procedure a lot. And also importantly, we always find a good projection angle, which typically is a 50 to 60 degree ipsilateral rotation, plus say 10 degree cephalic angulation, and that will separate the overlapping branches and put the origin of the inferior vesical artery in profile. And so in this case, we know that this is a prostate artery, but in fact, there is a large portion of overlap between the internal pudendal artery and the IVA. So we need to separate them before we move further on. So to overcome tortuosity, we favor the use of a curved microcatheter with a soft, unbraided soft catheter, such as a Merit Ministro. Sometimes we use a cerebral tip microcatheter to provide good support to overcome double sharp turns up and down. We use some Merit Swift Ninja. So in this case, this is the origin arising from the obturator artery. So this is short segment down and then acute up, acute down, like that. We need a good support from the catheter before we can support the guide wire to further cannulate the distal portion. So in this case, a Swift Ninja will do the job quite well. So by doing so, we will facilitate the advancement of the guide wire and the catheter. So how about for stenosis? So in this case, the same case after it turns around that very challenging double curve, it comes to multiple severe stenosis. So over here, we need to cross these stenosis, but in that case, the catheter was unable to get through this stenosis. So in that case, we advance the guiding catheter down, and then we change to a stronger micro wire, and then to push the catheter through. And then after the catheter passes through the passes through the stenotic sites, we change to a soft wire to a more distal portion to facilitate further advancement of the system. So by doing so, we were able to bring the microcatheter up to the boundary of the prostate, and then we can do the embolization successfully. So we're also obsessive about selective on the prostate artery alone. So we want to bypass all these branches in the vicinity, the superior vesical artery and the seminal vesical artery, and the middle rectal artery, inferior rectal artery. So we want to also embolize those arteries that are very close to the origin of the prostate artery in such a way that any backflow of the microsphere can go to this non-target sites. In this case, this is a rectal artery. So in this case, we embolize the rectal artery first before we do the embolization. So in this case, we know the prostate is there, but there are a number of recycle arteries. We want to bypass all these recycle arteries before we do the embolization. So by advancing the microcatheter to a more distal position, we were able to bypass all these recycle arteries. Likewise, in this case, the middle rectal artery and the branch to the seminal vesicle is also quite close to the prostate artery. So we have to advance it further to a distal site. So by doing so, we avoid non-target embolization as much as possible. So another point we need to look into is the intraprostatic anastomosis, which is not uncommon. We very frequently encounter those. There are different approaches to manage these cases. We can use coil embolization of the anastomosis, or we can use particle embolization of the prostate through the anastomosis. And we can also use a verapamil flow reversion technique. So first of all, for those branches that comes off the prostate artery and then directly going to the non-target sites, such as this case, the cavernosus artery of penis, we know we can catheterize this. If that is the case, we can put a coil over here. We can put a coil first, and then we withdraw the microcatheter, and then to complete the embolization procedure. Coil over here, pull back, do embolization. Or we can do particle embolization. Say in this case, the microcatheter tip is over here, the prostate is over here, the anastomosis, this is the internal pudendal artery, this is dorsal artery of penis, and the cavernosus artery. So in this case, we take away the microcatheter and then put it into the internal pudendal artery like this. And then we do the embolization from this side first to embolize all this anastomotic branch through the internal pudendal artery before we go back to the prostate artery. So this is after embolization. We know that there is no more anastomosis. And then we go back to the prostate artery. And then we can see that just the prostate is outlined without any flow into the penis anymore. So it works, but it takes time. So this approach that we have developed, verapamil flow reversion, will save us a lot of time. So a similar case with the microcatheter put into the boundary of the prostate and the anastomosis, dorsal artery of penis, cavernosus artery. So in this case, we do not do it the same way as the last case. We do not pull back the catheter and then select the internal pudendal artery. Instead, we just put in a vasodilator, a verapamil. So by doing so, the vasodilatation in this territory would lead to pressure drop. And then the flow from the penis would reverse, would go into the prostate. So even with the DSA, the pressure would be still less than that in the penis, so that the penis is no longer outlined. So this is effective. We can make use of this time window, which is about 4 to 11 minutes, and we can complete the particle embolization during this time window. So similar case, this is post-embolization. And this is another case, a branch of the obturator artery is outlined. Again, these are small branches, we cannot catheterize through this channel. So we do verapamil flow reversion. At this point, we give verapamil. So this is 1 minute after the verapamil delivery. We can see the anastomosis is no longer there. This is post-embolization. This is another case, even more challenging. So the tip of catheter is over here. Prostate is over here. You can see multiple anastomosing branch connecting to the middle rectal artery. So you know this is a territory of the rectum. You don't want to channel the particles through this anastomosis into the rectum. And it is very difficult to do coil embolization at multiple sites like this. We don't want to go back and then do the coil embolization at different sites. So instead we give verapamil. So after verapamil, 3 milligram, you can see all these anastomosing branches are not there anymore. So we are safe to do the embolization. So we usually dilute the verapamil and then give 3 to 5 milligram, depending on the size of the anastomosis. And then we do DSA to confirm. And we know the time window lasts for 4 to 11 minutes. So we further categorize the types of anastomosis into a direct type, type 1, or type 2 and type 3, which are branch type or plexus type. So for type 1, in which there's a dominant artery connecting the prostate to the non-target site, this can be accessed with guide wire and catheter and then do coil embolization. For the branch type like this, and also the plexus type, we know we cannot catheterize through the prostate, but for these cases, they are known to be very responsive to verapamil. So these are good cases where verapamil can help a lot. So we have a strategy for doing these cases for indirect type, in which we cannot access the anastomosis site with the catheter and to do coil embolization. We do verapamil. For the direct type, we know these are not responsive to verapamil, but we know these are easy to access with a microcatheter and then do coil embolization. So we know with using a verapamil, we compare using a control without using verapamil. The use of it do not have any detrimental effect to reduce the efficiency, to reduce the effectiveness of the embolization. So the clinical outcome is not different. It's not different from that without using verapamil. So for procedure management, we also give Votrient for pain relief, antibiotic for 1 week, and then we use pyridium for relieving the symptoms of peripheral pain and dysuria. So in conclusion, we think PAE is a good option to offer to our patients since it is minimal invasive and effective with many advantages. However, patient selection is important. Patient counseling before the procedure is also important. And PAE should be performed with great caution. And also the knowledge on the procedure skill is crucial for safety. So with that, I thank you very much for your attention.
Thank you, Professor Yu, for that very comprehensive talk and very interesting.
Thank you.
Any questions? I don't see any questions from the Q&A. Any questions from the panel?
Maybe Professor Yu, let me ask you a question. You use the particle to do the post-artery embolization. So what's the size of the particle? And there are many different microsphere. Do you find any difference in terms of different microsphere, like big block, microsphere, embolizing, something like this? Any difference in different types of microsphere and sizes?
Yeah, initially I use embolsphere 100 to 300 micron. And then eventually I use embolizing 100 micron with the hope that it can causes a better effect of embolization and necrosis. But then when we compare the results of the two groups, actually the clinical outcome does not show any difference in the clinical effectiveness. However, with the use of the smaller particles, it is associated with more severe adverse effects such as urethral pain or dysuria-like symptoms. Although these are transient, usually within 1 week, and also can be relieved quite effectively with pyridium. So I think the size 100 to 300 micron is good enough. And we also noticed that there are some difference in consistency of this different branding of microspheres. Some are more hard, which is less likely to conform to the vessel. The others are more malleable, so to say. But then eventually the outcomes are not different. So right now I am using 100 to 300 micron microspheres.
Yeah, Professor Yu, do you use cone beam CT for PAE? Does it help, do you think?
In the initial phase, I use it to help me to recognize the different branches to see which branch I safe to embolize and which are not. But then when I train, when the radiologist is being trained after such a learning period, I think DSA would be good enough to save a lot of time, and also the high definition, high precision with the image of DSA would be very sufficient for this purpose.
There's a question from the audience about recurrence rate after PAE. What is that number in your experience?
Recurrence rate from the literature is 15% in 6 years. In my own practice, it is about 10% after 3 years. It also depends on the initial response. If the initial response is good, and it is less likely to recur. Of course, there are other factors that lead to the recurrence. The hormonal factors, the overgrowth of the prostate, and also I think the bladder function eventually also has some factor in the recurrence.
Okay. I think there's another question on what is the average time to response? How long after the PAE do you expect the symptom improvement?
Well, in our experience, I think it's a good example to quote the acute retention of urine patient who presents complete urinary outflow obstruction. And then we observe how long does it take for the patient can wean off the Foley catheter. So we notice in the range of 3 to 14 days. After 14 days, the great majority of patients can have the Foley catheter wean off. About half of them can have the catheter wean off within 3 days. But then if we talk about the shrinkage of the prostate size, actually the size will shrink starting from 2 weeks, and then quite obviously after 3 months, and then can persist. I mean, the reduction in size would progress up to 6 months, 7, even 9 months.
Okay, there are a few more questions in the Q&A, but I think in the interest of time, we will move on. May I trouble Professor Yu to answer them on the Q&A, type the answer in so that the rest of us can also see. For the next speaker, I'll let Ricky to introduce.
Okay, the next speaker will be Professor Yuan Sun Hyung. Professor Hyung is Associate Professor of the Radiology Department of Tam Ha Hospital of Vietnam. His interests including interventional UFE, prostate artery embolization, embolization in varicocele, and treatment of pelvic contraction syndrome, as well as urological intervention. And he has published more than 80 papers in domestic and international peer-reviewed journals and 5 books. And today, the topic of his lecture is renal embolization of tumors. Professor Hyung, please. Thank you very much.
Good afternoon, everyone. So first of all, I would like to thank to Mr. Tang Byung-Shu to invite me to present the subject renal tumor embolization. My outline is I talk about the literature indication, renal artery embolization, renal artery anatomy, AML, RCC, and complication of RAE. So RAE performed from 1970 by the Anman. He performed the renal artery embolization by the cause hematuria, and after that, up to now, many published on the public, and the indication of the RAE is to divide 2 parts. The first, the renal injury, for example, traumatic iatrogenic, for example, biopsy, PSCNL, sorry, vân. And renal tumor, it means embolization for AML and RCC. Today, I present about the AML and RCC. So the anatomy and technical, each person have a 2 renal arteries, one in right side and one in left side. It's come from the aorta, abdomen aorta, at the level L1, L2. And as you know, the anatomy of the renal artery is the end artery, so it means no collateral. So it's very important for everyone who want to do the renal artery embolization. So the variant anatomy, so it's many kinds. So they divide 2 types. Type 1 have a subtype, 4 subtype, and type 2 have a subtype. It's depend. Type 1 is depend on the artery in the healers of the renal. This may be the 1 or 2 renal artery, and have accessory raising from the aorta, abdomen aorta to the upper bone, or the early division. And type 2, we might have 4 subtype. So it means the other kind of the renal artery. So which material you should use for the renal artery embolization? So the first, you should take the catheter, the pigtail. So pigtail for the Roman balance. You take the abdominal aorta angiogram, and after you insert the renal artery by Cobra C2 or SOS catheter or Simon, etc. And for embolizer, you should selective or super selective in the brand which you want to embolize. You may use a micro catheter from 2.0 to 2.7 French. So material embolizer, the 2 kinds of the material embolizer, temporal and permanent. Temporal like the shown. And permanent is like the PVA, amorphous, NBC glue, absolute ethanol, coil, etc. So we are the puncture. It's via the femoral asset. It's better. And belongs you do the belongs the angiogram. You use details at the liver level, the power and L1. You put the catheter and you do the angiogram with the flow rates at least from 8 to 10 mils per second, and total volume from 25 to 30 mils on DSA. if you already have a CTA or MRA, so it's not need to do the global balance angiogram. And after that, you select the angiogram, the renal arterial, and you found some branch to fitting to the tumor. You can selective or super selective this brand, and after that, you do embolize. After you check the angiogram for the embolize total or Batchian of the tumor. So like that's the first time that you put the big tail in the external D12 and L1. You make the aorta angiogram. You see the owner brand from the aorta. And with the right renal kidney in the left renal kidney. And for example, this case, you do the total global bilan. You see the left side have a accessory renal artery, and you see the main left side renal artery. You see some one brand there. It's a surprise or inferior upon of the right kidney. So it means it's the apparent renal artery. It's the right renal artery. It's rising from the hillock of the left side. For example, you have MSCT, or you can make the VRT. You see the whole of the brand of the renal artery. This you have accessory renal artery, and the right side you see the accessory of the renal artery also, and the many branch division too early. So how about the renal angioma? AML is a benign tumor. It contains one of the soft tissue, and it's a variable of the vessel inside. The incidence less than 3% in the general population. So the characteristic of the AML have a macroscopic fat. So it means the density is minus 20 HU. Or sometimes you have to distinguish AML and RCC. When the AML have a poor fat, so AML always absent of conjugation and homogeneous enhancement. And sometimes you have to based on the tumor size and clinical information to distinguish this. So IEE is a well established as a first line therapy for the treatment of AML. So classification of AML. So it's beyond of the vascularity inside the tumor is divided three grades. Grade 1 is minimum vascularity, and grade 2 is a moderate vascularity, and grade 3 the marker the vascularity. So sometimes it's depend on the aneurysm inside of the AML. If the aneurysm inside the AML is less than 5 millimeter, it's less of the risk of rupture, but the aneurysm inside the AML have a diameter larger than 5 meters. It's have a high risk of rupture. So indication. So if AML have a size less than 4 centimeters, so no symptom, we maybe follow up. So indication RAE for AML, the size more than 4 centimeters, or the period or active hemorrhage, frying pan, hematuria, or mass effect, or the AML have contain aneurysm larger than 5 millimeter. So it means it's the high risk of the hemorrhage and high risk of rupture aneurysm. So it should do the ARE. So first of all, for this case, the big AML on the right side kidneys, you do the angiogram, you see some zone of the hypervascular in here, and after that you do silver selective of microcatheter in here. You see the whole of the AML in here. We do embolize with only ambuphers. and they do it under fields, and after the recontrol, you see the all of the AML's occlusion total, and it's keeps the normal renal Parkinson is very good. And another case, they do the embolization AML with lipidone. You see it's the in the left side, AML, the left side, you see do the Govan angiogram, you see the rone hypervascular, and after you insert the microcatheter too distant to see the whole of the AML hypervascular in here, and you inject the lipidone with the particle. And another case, very huge AML in the right side. You see it's in CT with contrast, and some you see it's maybe a small aneurysm, and it's the feeding contrast in here. And to the angiogram, you see the big hypervascular in some small, maybe small aneurysm, and to the emboli with the particle and the coil to cutting up the main branch supply to the AML. After the embolizer, you see the whole of the, you can keep the almost of the renal Parkinson's. So how about the tumor thing? So it's depend on the fat content in the tumor. If the AML have the high fat, it means it's more than 50% fat content. It's already about around 15% of volume. And with the AML with low fat content, it's maybe a decrease of the volume after the embolize about 80% or more than. So one of the research from Tomia, he follow up with 7 cases from 9 to 54 months. He found the volume reduction of the AML is from 48 to 93%. He do the MRI with lipidone mixed with ethanol. So it's effective and safe procedure when used with microballoon. And the last is renal cell carcinoma, RCC. It occurs about 4% of all case cancers in US. So it's 2 main indications for the RCC. So pre-operative or palliative ablation for some RCC with the symptom or operator of ACC. So this guy also do apply with very big RCC in the left side. You see the do apply and coil and total apply. Then after that's the do the nephrectomy left side. And another case, you see the small RCC in the upper bone of the right side. You do angiogram, the Robin angiogram aorta. You see the right side of the renal artery. You see there's some small brand maybe surprise for the tumor, and you do redo the renal artery selective. You see the more clearly. And after that, you insert microcatheter inside, and after you apply with the particle and lipidone. So how they use the lipidone? If they use the lipidone mixed with particle, so it's easy for you to see on CT scan after both procedure, and you can do the IFA is very easy to see to recognize where is the tumor. The other case, the man 58 years old have a huge RCC in the left side, and they do the embolize with the total of the renal arteries left side and tumor with ethanol, absolute alcohol. So after inject absolute alcohol in here, you recheck abdomen aorta that you see the occlusion total of the renal left renal arteries, and after that this patient had done nephrectomy. And another case, you see the big RCC in the upper bone of the right side, and you do the renal artery angiogram, you see the big tumor, and after you do apply with microparticle, and you see the occlusion total of the tumor and the other brand of the normal, but this patient have indicated of nephrectomy in the right side. So you see, we do the embolization. They do the embolization. It's very good. And another case, 53 female have a RCC in the left side with the diameter about 12 centimeter. They do embolization with 3 acrin gelatin microfarad, and after that the observation have indicated nephrectomy, and during the surgery the patient have a blood loss only 300 ml, so it's not need blood transfusion during the surgery. And the other side, so one of the research from Henas, he divided two parts, one part non-abrasion group and one part of tongue arterial abrasion. He follow up the 4 patients in each group, and the size of the group non-abrasion is too small, less than the group the abrasion. So he found the own of the blood after surgery. So in the group A, it's have a lots of much blood than the second group with abrasion. And Govani, he follow the 64th patient. We divide the two group. One group the 30 with abrasion before surgery, and 34 no abrasion before surgery. So he found the blood loss in the group A is available 250 ml, and the group 2 is 400 with signification. So it means embolization for RCC before the operator is a reduce of the blood loss volume, and it's no complication different between two groups. So he concludes RAE the shape procedure, and PI seem to be is tool surgical mechanism of the lower mass and advanced disease. And for the palliative abrasion, this patient 91 is too old, have a hematuria and anemia, and left flank vein with with RCC in the upper bone of the left kidney. So this patient have a surgery is much more than aggressive than the thyroid abrasion. So they choose the abrasion for reduce the symptom of this patient. You see the supersensitive of the brain supply for tumor, and they do the abrasion with particle and some microcoil. So when surgeon can do after RAE, so almost of the research, as I said, about the after less than 48 hours, if you do the surgery more than 75 hours after operation, it's maybe it's cause the more the blood loss is more than, because it's due to the secondary the collateral vessel formation. So some side effect of RAE is very mild. it's not severe. Sometimes they have a pain. It's a syndrome of the both embolization, or sometimes fever, or sometimes bleeding. It's a rupture of the tumor, and sometimes nausea and vomiting. So conclusion. So IE is a safe and effective technique, but you always remember the renal artery is an artery, so you should do embolize distant. You should do the bilan MSCT or MI or DSA before you do the embolizer. Some material you can use the PVA, NBC group, absolute alcohol, liburon. Indication for AML, the only AML have the symptomatic or have a risk for spontaneous rupture. This means the diameter of the AML less than 4 centimeters or aneurysm inside of the AML have a size more than 5 millimeter. Or indication for RCC is two main indication. It's a preoperative selection, palliative embolization. Thank you very much.
Thank you, Professor. Thank you, Professor Heng, for your very interesting and excellent presentation. So there is a question from the audience. In case of bleeding diffuse AML occupying the entire kidney with grade 1 angiographic pattern, that is small stretched vessel plus or minus stains on angiogram. Any tips to guide which part of the kidney to embolize?
Yeah, it's very interesting question. So for this that case, we should do the embolize with absolute alcohol. We prevent with micro balloon to prevent regress of the absolute alcohol, because if you do inject absolute alcohol, it's go fast from to the small vessel, and you maybe control the bleeding.
And also, in your presentation, it seems that sometimes you use particles, sometimes you use alcohol to embolize AML. So what's your, how will you choose the embolic agent in AML?
Yeah, so in AML, if you choose the particle, so it's less of severe the complication. So it's easy to do the embolizer. If you use the absolute alcohol, it's if you cannot control. But some suggest on the public, they said if you do the embolizer with the absolute alcohol, you should make with absolute alcohol with the lipidone, the oil, contaminant, so you can control the non-target embolization. One of the doctor from Japanese, he do the embolize with the absolute alcohol. He always use the micro balloon to occlusion of the main feeding vessel for AML, and after that he injects absolute alcohol. So it's keep a lot of the complication. So if some beginners do the embolize for AML, so I think maybe it's not use alcohol, but alcohol is a good reason, a good reduce the volume of the AML after the procedure.
There's another question from the audience. Based on your experience in AML with microaneurysm, say for example 5 mm, do you think particle embolization alone is okay, or do you need some microcoil?
So if you do the embolizer with only microcoil, so it's occlusion proximal. So it's maybe recurrent of the collateral. So it's for a long time, it's not keep the volume of the AML, the reduce maximum. But you do the with particle, the small particle come far from, so distant to the small vessel. So So I'm sorry. So it's keep the maximum of the embolize, the total of the vessel in the AML. So coil is not effective. Coil not effective. Only coil for AML is not effective. Yeah.
Because we are a bit running out of time, so thank you very much, Professor Hyung, for your presentation and answer the questions. So should we go to the corporate member presentation now? Yep. Thank you very much.
Yeah, thank you.
This video will show you how to perform a TACE procedure in an Azurion Interventional Oncology Suite with the Embo Guide Planning and Guidance software. In this TACE procedure, several tumors will be treated with drug-eluting microspheres loaded with anti-cancer drugs. First, the physician will look at the pre-procedural CT images to see where the tumors are located. The patient is now into the room and is placed as far as possible to the head end of the table. This is very important since you will have the ability to perform the procedure with the C-arm in a propeller position and still be able to visualize the groin when necessary. The patient is covered with sterile drapes, and the IR staff is preparing the room and the materials which will be used for the procedure. When all preparations have been done by the scrub nurse, the interventional radiologist scrubs in. The radiologist starts the procedure by explaining to the patient what will happen in the next minutes of the procedure. Once the introducer needle is in place, a short guide wire is advanced into the needle and the system is brought into working position. Here you can see the C-arm can reach the groin in the propeller position due to the positioning of the patient as high as possible on the table. The correct protocol is selected on the touchscreen module, TSM, for the right procedure acquisition program and FlexVision monitor layout. When access to the femoral artery is established, the short guide wire is advanced and the needle is replaced by a sheath. Once the sheet is in place, the catheter and guide wire are introduced into the femoral artery. Before the DSA of the celiac trunk is performed, a DSA of the superior mesenteric artery, SMA, is usually acquired to visualize possible anatomical variations of feeding vessels into the liver coming from the SMA. When needed, also patency of the portal vein can be visualized in this way by waiting for the venous phase. The catheter is advanced into the celiac trunk and an acquisition is made to check the flow dynamics. Now the catheter needs to be advanced into the common hepatic artery. This is done with the help of the 2D road map function. The catheter is advanced from the femoral artery to the celiac trunk, and then more selectively via the proper hepatic artery into the right hepatic artery. Once the catheter is in the correct position, the system is set up to perform a dual cone beam CT scan. To have an optimal result, the patient's arm should be out of the X-ray beam to avoid streak artifacts in the cone beam CT volume. Hands under the head would be the best position if this is possible. Also take care that no wires and infusion lines are hanging from the table. Be sure that the lead shields are out of the C-arm pathway to prevent collision during setup. The proper injector protocol is set on the power injector. The detector is rotated to the landscape position. Check in the AP position if the liver is in the region of interest by pressing the fluoroscopy foot paddle. It's important to have the liver in the center of your image, especially when you're using the cone beam CT open. Check in the lateral position that the liver is in the region of interest by pressing the fluoroscopy foot pedal. Make sure when doing this that you only adjust the height of the table, since we already centered the liver in the AP position. Select the appropriate dual cone beam CT open trajectory protocol. Set the X-ray delay time and the interval time. Now press the Accept button and move the C-arm to the end position. You should be aware that during cone beam CT dual setup, the body guards are active. Press the Accept button again to move the C-arm to the start position. The patient will receive breathing instructions and an explanation of how the cone beam CT scans are performed. Since this will be a dual cone beam CT scan, there is an interval time between the two cone beam CT scans. This can be used for the patient to breathe in between. Press the Acquisition button in the control room. The cone beam CT starts with an X-ray delay. During this delay time, the contrast injection is already starting to have a perfectly filled vessel tree. The images of the arterial phase are sent in real time to the interventional work spot. After the arterial cone beam CT scan is performed, the patient can be asked to breathe superficially just before the next cone beam CT scan. Hold the acquisition switch until both cone beam CT scans are acquired. Meanwhile, the interval time is displayed on the monitor. After the cone beam CT dual acquisition, the patient's arms can be put next to the body for more comfort, and the injector is disconnected from the catheter. On the left, the arterial phase will be present, and on the right, the late phase will be present. Zoom the volumes and scroll through both volumes to check if all structures are clearly visible and to check if all lesions are in the volume. If you're satisfied with the result, you can merge the arterial and late phase with the spacing slider and scroll through the volume to check if both volumes are matching. Proceed to the Embo Guide application. The application opens automatically in the segment step. The late phase will be visible and the arterial phase will be hidden. Select a single viewing pane and scroll through the cone beam CT volume to identify the lesions for treatment. When a lesion is identified, press on the New button. Click on the lesion, hold the left mouse button, and drag the mouse until the complete lesion is covered. Repeat these steps until you have segmented all the lesions. Scroll through the cone beam CT volume to check if all regions are segmented properly. It's a good idea to check the segmentation in all the different planes. Zoom in on the lesions and check if they are properly covered by selecting a single lesion. When all lesions are identified, proceed to the planning step. Select the axial view for the best view on the rib cage and the spine to get a good overview of what to cut out. Select the 3D volume single pane for an optimal view. Rotate the volume so that the ribs and spine are not overlapping the vessel structures. Select Cut and draw the yellow line around the ribs and spine. Be careful not to take out the lesion or the vessel structures. These will not be visible anymore during the procedure. The next step is to identify the catheter. Rotate the volume to obtain a clear view on the catheter. Select the Set Catheter button and move the mouse pointer to the catheter in the 3D volume and click on it. A green dot is placed in the catheter to identify the position. Notice the Set Catheter button has now changed into the Add Feeder button. Now that both the tumors and the catheter positions are defined, Embo Guide is able to determine the feeder paths. Select Auto Detect to find the feeder paths from the catheter to the identified tumors. As you can see, the algorithm detects the feeders automatically. Sometimes a feeder is not detected automatically. This can be due to a lack of contrast, patient movement, or a mismatch in the registration. It is still possible to add feeders manually. Select the Add Feeder button and click on the tumor to add feeder manually. Embo Guide is still able to add the correct vessel path. Check the result in all planes and see if all feeding vessels follow the correct path with the Follow Selected Feeder slider. Once satisfied with the result, proceed to the guidance step. A 3D roadmap becomes visible on the interventional work spot. In the roadmap, the vessel paths to the tumors are visible. When the microcatheter is in place, an acquisition is made to check if the catheter is in the correct position to embolize. Contrast material and the embolization beads are administered to the tumor tissue. Since multiple tumors are identified with EmboGuide, it's easy to go to the next lesion after the first tumor has been embolized. An acquisition is made to check if the catheter is in the correct position for the next embolization. To prevent reflux, the catheter is further advanced into the feeding artery. This means that all administered embolization material will flow to the tumor tissue and not to the healthy tissue. After the procedure, the results of the embolization can be checked by performing a cone beam CT scan to see if all the feeding vessels are blocked. Several studies have demonstrated the added value of using CBCT in TACE procedures. However, sometimes performing a cone beam CT can be challenging to the less experienced user, as there are several steps that need to be followed in the correct sequence. The latest generation, Azurion, offers a new application called Smart CT that walks the user through the whole acquisition, providing step-by-step guidance with clear instructions and pictorials. Smart CT also offers easy 3D visualization tools accessible directly on the touchscreen module at tableside. You can scroll, zoom, pan with the touch of your fingers. For the less complex TACE procedures, Smart CT offers a simple lesion segmentation tool on the TSM. You can cut out the ribs and spine from your 3D view directly on the TSM. The vessel analysis tool can help you find the feeder paths by simply defining the start and end point of the vessel path. We hope you have found this video useful. We thank you for your attention. Innovation and You, Phillips.
Yeah, we thank our industry partners for their collaboration and sponsorship. So this is one platform that we could engage them and I guess extend our appreciation. Okay, we'll move on with the program. The next speaker is Dr. Kristen Lee. Kristen is a colleague of mine. She's a consultant IR at the Singapore General Hospital. Kristen did her radiology training in the US. Her residency was at the Mallinckrodt Institute and her fellowship was at UCSF. After that, she spent about a year in the Daughter Institute. So she's very well trained. And today she'll be speaking to us on obstetric embolization. Kristen, please.
Hi everyone, my name is Kristen Lee. I'm an interventional radiologist practicing at the Singapore General Hospital. I would like to thank the organizing committee for inviting me to speak today. I'll be discussing the embolization in obstetric emergencies, what an interventional radiologist should know. The most common obstetric emergency that IR often encounter is postpartum hemorrhage. It is one of the leading causes of maternal morbidity and mortality worldwide and can be caused by multiple etiologies. Postpartum hemorrhage is defined as greater than 500 cc's of estimated blood loss in vaginal delivery and greater than 1,000 cc's of blood loss in EBL and cesarean delivery. Severe postpartum hemorrhage is defined as life-threatening blood loss in the setting of one or more of the following: requiring blood transfusions, need for escalation of intervention, transfer to the ICU, drop in peripartum HB of more than 4 grams, and bleeding resulting in maternal death. Postpartum hemorrhage is also differentiated based on time of presentation. When presenting within the first 24 hours of delivery, it is categorized as primary or early postpartum hemorrhage. After 24 hours, up to 12 weeks postpartum, it is considered secondary or late postpartum hemorrhage. The 4 T's are often quoted as a mnemonic for postpartum hemorrhage. This includes tone, tissue, trauma, and thrombosis. Of the primary causes of postpartum hemorrhage, uterine atony is the most common cause. In fact, uterine atony accounts for 70 to 80% of all postpartum hemorrhage. Other etiologies of primary postpartum hemorrhage includes laceration, retained placenta, abnormally adherent placenta, coagulopathy, or uterine inversion or rupture. Most common causes of secondary postpartum hemorrhage is retained products of conception. Other causes include vascular injury or anomaly, involution of placental site, infection, and again, coagulopathy. A basic knowledge of the causes of postpartum hemorrhage is essential, just so that we know how to best manage and treat postpartum hemorrhage. Based on reported studies, transarterial interventions or embolization in the setting of postpartum hemorrhage have a high technical and clinical success rate with low reported complication rates. Reported rebleeding rates ranges from 5.2 to 13.5%, and no significant adverse events related to fertility or radiation exposures has been reported in the literature. The initial management of postpartum hemorrhage focuses on aggressive resuscitation of hemorrhagic shock while attempting to achieve hemostasis. At the initial stage of management, uterotonics such as oxytocin would be increased to allow for more effective contraction of the uterus and vasoconstriction of the myometrial arteries. Other conservative measures would include direct balloon tamponade or direct tamponade with vaginal packing or intrauterine balloon placement. Also administration of a thrombotic agent such as tranexamic acid would also be considered. The American College of Gynecology has recommended standardized checklists as well as stage protocols for care escalation in the management of postpartum hemorrhage to allow for early detection and response in the setting of maternal bleeding. So it's often categorized into 4 stages. So the first stage is when EBL is greater than 500 cc's in a vaginal delivery or greater than 1,000 cc's in cesarean delivery with normal vital signs and blood tests. The second stage is when EBL is greater than 1,500 cc's or more than 2 uterotonics is being used, but vital signs are still stable and blood tests are normal. Stage 3 and 4 is usually when IRs get involved. That's when transfusions are required and deterioration of vital signs are noted, as well as signs of organ hypoperfusion. When conservative management fails, patients are urgently brought to the OT for compression sutures, hysterectomy, and that's also when IRs would be called as well. It is important to keep in mind that usually with young women, they have a very significant cardiovascular reserve. So by the time that tachycardia and hypotension sets in, there's usually substantial blood loss. Therefore, early recognition, even before the vital sign changes, is extremely important in postpartum hemorrhage to allow for successful management. So on the IR side, when you're called, it is important to ensure that there is sufficient support from the clinical team, such as ICU, from anesthesia, and you really want to ensure that the massive transfusion protocols is activated and also performed appropriately to allow for replenishment of clotting factors in addition to packed red cells. It is also important to communicate with the attending obstetrician to understand what has been given and what has been done. For example, if a thrombogenic agent has been given and you're doing an embolization, you may not want to leave the sheath in place afterwards in fear of forming clots or thrombosis. And of course, it would be helpful to know if there's any surgical arterial ligations that have been done in attempts to achieve hemostasis. So now we'll just go through a quick case. A 34-year-old woman status post-cesarean delivery for twin pregnancies at 36 weeks. The delivery was uncomplicated, but she presents with persistent vaginal bleeding. She was initially managed at the outside hospital, was given 8 units of blood and subsequently discharged. She then presented again at post-op day 13 with heavy bleeding and was noted to be hypotensive on triage. Massive transfusion protocol was activated twice for this patient. A CTA was obtained to exclude or identify any potential sites of bleeding, considering that this is a secondary stage or cause of postpartum hemorrhage. On the CTA, findings are in keeping with retained products of conception within the uterine cavity, with actually active bleeding that's highlighted by the red arrow here, both on the arterial as well as the venous phase. During the initial resuscitation, this patient was noted to be extremely coagulopathic and was diagnosed to have acquired factor VIII inhibitor. After initial resuscitation and appropriate replenishment of clotting factors, she was sent to the OR for evacuation of clots, as well as a Barclay balloon insertion under GA, after which she was transferred to IR for an uterine artery embolization. So initially, we have skipped a pigtail angiogram just because a CTA was performed. The left internal iliac artery and subsequently the left uterine artery was selectively catheterized with a 4 French C2 Cobra diagnostic catheter. You can see that the left uterine artery is extremely hypertrophied, but there is no discrete arterial extravasation identified. This was successfully embolized with a temporary embolic agent in which we use calibrated gel foam here. One note to keep in mind in terms of performing uterine artery embolization is that oftentimes gel foam is used as the most common agent. It provides temporary cessation of flow, usually recanalizes within 3 to 6 weeks time. Sometimes particle embolics can also be considered. However, one should avoid using very small particles to avoid uterine ischemia. Also, it is important to keep in mind that time is often of the essence when it comes to postpartum hemorrhage embolization. So deep cannulization of the uterine arteries are not always necessary and may not always be capable to do just because vessels can be very clamped down. Gel foam embolization can then be performed via the anterior division of the internal iliac artery to just allow for quick hemostasis. So after the left was embolized, the right was selectively catheterized using the same C2 Cobra by forming a Wattman's loop here. And again, we see a hypertrophied uterine artery, but no active extravasation was identified. This was again embolized with a temporary embolic, which is calibrated gel foam here. Another note to keep in mind when performing uterine artery or internal iliac artery embolization in the setting of postpartum hemorrhage is that both sides should be treated whether or not an arterial blush is seen. So here is a completion pelvic angiogram for that same patient. We actually performed it with the Barclay balloon inflated. We then deflated the balloon and waited for about 5 minutes to repeat the angiogram to ensure that there is no residual bleeding that is masked by having the balloon inflated. The patient did quite well, was then stabilized after the embolization and was discharged in the next few days. So next, I would like to discuss our role in invasive placentation. Invasive placentation refers to placenta accreta spectrum, where placental tissue invades into the uterus with varying degree of severity. Accreta really refers to the invasion into the endometrial layer. Increta invades deep into the myometrium layer, and percreta refers to invasion beyond the serosum. Placenta accreta spectrum is an unusual but morbid etiology of postpartum bleeding, and the incidence of which has really increased over the last 2 decades, paralleling the increase of cesarean deliveries. In regards to the role of uterine artery embolization or any trans-arterial intervention here for a morbidly adherent placenta, there are actually one, in the setting of significant postpartum hemorrhage, and 2, it can also be utilized in the setting of uterine preserving cesarean delivery where the placenta is left in situ. Due to significant morbidity, patients with high suspicion of invasive placentation are often referred to high-risk OB clinics or tertiary referral centers and are managed under a multidisciplinary care team. The aim is to electively deliver at 35 to 36 weeks after neonatal lung maturity to minimize risk of maternal morbidity. Recent cohort studies have shown that women managed under a multidisciplinary accreta team were less likely to require large volume blood transfusions, ICU admissions, as well as reoperation within 7 days of delivery. This is the usual model that we would follow here at SGH. Through the high-risk OB clinic, a MDT pre-op evaluation is performed to ensure that appropriate blood tests, imaging, and counseling is done. The patient will then be electively admitted at the desired time. Prior to the elective cesarean delivery, a pre-op huddle with all the relevant specialties will be done to ensure that all roles and responsibilities, as well as contingency plans, are established. In some institutions, prophylactic internal iliac artery balloon placement would be requested as part of the care for elective cesarean deliveries with anticipated large volume blood loss due to increta or procreta cases. 5 French balloon-mounted catheters, such as Fogarty balloons, are inserted via bilateral femoral arteries into the anterior division of the internal iliac artery. This can be done either in the OT prior to delivery or actually in the IR suite. The rationale of this is to reduce the flow to the placenta and uterus during delivery to minimize blood loss. However, when it comes to studies in the literature, the literature really provides a little bit of a mixed view. Some retrospective studies have demonstrated a reduction in large volume blood loss and the need for massive transfusion when prophylactic balloons were placed. However, there is one very small randomized control trial that didn't really demonstrate any treatment difference. So a lot of times this really is case by case and really dependent on the center's expertise. So here's a quick case that we can discuss again. A 38-year-old woman referred from a private hospital with concerns of abnormal placentation. She was evaluated at the high-risk OB clinic, and the MRI actually showed placenta previa with placenta increta with worrisome features of procreta. Therefore, an elective cesarean delivery was planned with ureteric stent placement as well as internal iliac artery balloon placement by IR. So here are some intra-op angiographic images that are obtained before delivery. Access was first obtained via the common femoral artery on both sides using ultrasound guidance. A diagnostic catheter was then advanced into the internal iliac artery. The diagnostic catheter was then exchanged for the balloon-mounted catheter over a guide wire. The balloon will then be tested and inflated under fluoroscopy. The amount that is used to inflate the balloon would be marked down, and then the balloon would then be deflated. All sheets and catheters will then be secured in place. The amount that is used to inflate the balloon would be clearly marked and also announced to the team as well. It is very important to make sure you do not overinflate the balloon. So you just want the balloon to slowly conform to the vessel rather than having a very plump, round balloon to over distend the vessel here. Here's a case that's done in the angio suite. You can see the guide wires are left in place along with the balloon mounted catheters to ensure that there's no dislodgement along with patient movement from the IR suite to the OT. The amount that's used for the balloon inflation is also clearly marked on the angiographic images. Additional special considerations, of course, if you're doing this in the OT and even in the IR suite, careful draping and maintaining sterility is extremely important. When the balloons are in place, it is important to keep track of time of when the balloon is inserted, when it's inflated, and when it's deflated. Ideally, if you can accompany the patient for the balloons to be inflated, that would be the most ideal to ensure that they're inflated in the right way. So moving on to vascular injuries and anomalies. Vascular injury and anomalies are usually secondary to iatrogenic trauma due to inadvertent vessel ligation or blunt trauma from vaginal or cesarean births. Vessel injury would include lacerations, pseudoaneurysm formations, and the usual culprits are from the uterine artery, ovarian artery, iliac arteries, and the inferior epigastric arteries, especially in the setting of cesarean delivery. When immediate bleeding is seen, the culprit vessels are often identified just by direct visualization. However, if bleeding is refractory or delayed, imaging can be helpful to identify potential sources of bleeding and injury. Uterine AVM or AVFs are very rare causes of late postpartum hemorrhage. In a prospective study looking at 959 patients, AVMs post-delivery are only identified in less than 1% of patients. Cross-sectional imaging such as CTA, MRI, MRA can be helpful in delineating the inflow and outflow, as well as the vascular nidus for better treatment planning. In regards to the choice of embolic, it's really largely operator dependent. A lot would choose to use glue, for example. However, maybe one common principle is to avoid small particles, especially if the shunts are large, to avoid non-target embolization through the shunts. Here's a case of a 30-year-old G8P8 woman that's sent to the A&E after a syncopal episode 12 hours after delivering at home. On arrival, she was hypotensive. Immediately, she was brought to the OT for evaluation. However, following initial evaluation, they can't quite determine the etiology of bleeding, and IR was called to the OT. So on the initial angiogram, you can see that the patient is very intravascularly depleted, as the vessels are very small in caliber, including the uterine arteries. Interestingly, on the right ovarian artery, clearly there is a laceration with active extravasation. This was selectively catheterized, and glue was used to embolize this lacerated artery. She did well, subsequently stabilized, and was subsequently sent home after a couple of days. Lastly, I would just want to touch on ectopic pregnancies briefly and the role of IR in these scenarios. In some rare cases, IRs would be called to perform prophylactic embolization prior to DNE in ectopic pregnancies, and this is usually in the setting of scar ectopics or cesarean scar pregnancies. Cesarean scar pregnancies is estimated to be 1 in 1,800 pregnancies, and can lead to significant maternal hemorrhage, uterine rupture, subsequent hysterectomy with loss of fertility. Therefore, some centers have performed a combination of prophylactic uterine artery embolization prior to DNC. This would be an example on the right here. I just have one last case to share today. This is actually an ectopic pregnancy, a cervical ectopic pregnancy, unfortunately discovered at 13 weeks. Due to the high risk of bleeding for termination, a prophylactic uterine artery embolization was performed prior to termination for this patient. The pelvic angiogram here shows a very hypervascular gravid uterus. The uterine arteries are selectively catheterized and embolized with gel foam with decreased vascularity at the end, and she successfully underwent an evacuation afterwards. So some take-home points from today's discussion. Postpartum hemorrhage is one of the leading causes of maternal morbidity and mortality worldwide. Early detection and response is crucial to the successful management. Transarterial embolization in the setting of postpartum hemorrhage is safe and effective, with low reported complication rates as well as lower bleeding rates. General approach to embolization in postpartum hemorrhage is to, number one, embolize bilateral uterine arteries, or embolize the anterior division of the bilateral internal iliac artery if the uterine artery cannot be easily assessed. If the initial uterine artery and/or the internal iliac artery embolization fails, it is very important to identify other potential causes and collateral bleeders. Placenta accreta spectrum is an unusual but morbid etiology of postpartum hemorrhage, so when possible, this should be managed under a multidisciplinary care team to optimize clinical outcome. Beyond just urgent intervention for hemorrhage, IR can also be involved in prophylactic internal iliac artery balloon insertion. Vascular injury and anomalies are usually secondary to iatrogenic trauma due to inadvertent vessel ligation or blunt trauma from vaginal or cesarean births. When bleeding is refractory or delayed, cross-sectional imaging can be helpful to identify bleeding source and also to formulate a treatment plan. Finally, prophylactic uterine artery embolization followed by D&C is a viable strategy in minimizing blood loss in certain high-risk ectopic pregnancies. Again, this would be discussed at a case-by-case basis based on center expertise. With that, I will end my talk today and I will take any questions from the audience. Thank you very much.
Thanks, Kristen, for that very comprehensive review of obstetric hemorrhage. I think we have quite badly overrun. I think in the interest of time, we will go on to the next talk. Ricky, can I trouble you to introduce?
Sure. The next speaker will be Dr. Nacha Pinjaran. She graduated from radiology residency training from Chulalongkorn University in Bangkok, Thailand. She then joined the faculty in 2007. She received interventional oncology fellowship training in Oregon Health and Science University in USA. After completing her fellowship in 2012, she came back to Thailand to be attending IR. Her main interests including transarterial and percutaneous treatment of HCC and other malignancies. Today, the topic of her lecture will be portal vein embolization. Dr. Nacha, please.
Good afternoon, everyone. Today I'm going to talk about the principle of portal vein embolization, techniques, and clinical application. PVE has been described over 30 years with the basic principle of preoperative portal vein occlusion in the tumerous lobe. This will resulting in redirection of portal blood flow and also biochemical changes. Subsequently, the embolized lobe will be atrophy and the contralateral lobe will be hypertrophy. Nowadays, PVE has been indicated in any patients who have inadequate future liver remnant for major hepatic resection. In general, the FLR should be at least 20% in the patient without underlying liver disease. At least 30% for patients who had compromised liver from chemotherapy, diabetes, or fatty infiltration, and more than 40% for the patient who had liver cirrhosis. Volumetric measurements from CT or MRI are required in all the patients. Tumor volume has to be excluded from the total liver volume, and the standardized FLR is more accurate to estimate the functioning liver volume based on the patient's size. In HCC patients who had chronic liver disease, the inoscianine green retention test has been widely used to evaluate the hepatocyte function. The cutoff value is less than 20% to consider major hepatic resection. The portal system can be accessed by two routes. Transileocolic is the surgical access, which requires general anesthesia and has risk of bowel obstruction. The more popular access route is percutaneous approach. There are two different techniques, contralateral approach and ipsilateral approach. For right PVE, contralateral approach is when you access from the left portal vein. The catheter manipulation will be easier, but you may cause injury to the FLR. Ipsilateral approach is preferred to avoid damage, but the acute angle is more difficult to embolize and usually require reverse curve catheter. Many kinds of embolic materials has been described for PVE. Depends on operator experience and preference. In general, temporally embolic material should be avoided due to higher risk of portal vein recanalization. PVA particles are easy to control, but takes longer time to reach complete occlusion. It can be used in combination with proximal occlusion with coil or vascular plug. With liquid embolic materials such as glue mixture or absolute ethanol, the procedure time will be shorter and the hypertrophy rate is reliable. However, it requires more experience of the operator and has strong inflammatory reaction. Segment 5 portal vein branch is always my first choice. The parallel of vascular alignment and the needle insertion will make guidewire insertion easy. Furthermore, anterior branch access has been associated with the lower complication rate. To avoid FLR injury, ipsilateral approach should be considered first. However, in case with large tumor, ipsilateral approach may be difficult or impossible. When portography at main portal vein is done for vascular mapping, the ideal projection to open up the bifurcation is right anterior oblique. With cranial or chordate oblique can be used to visualize the bifurcation between right anterior and right posterior portal vein. The portal vein anatomy has to be considered for embolization planning. Bifurcation of portal vein and right posterior portal vein arising as the first branch are two common variations. PVE in both conditions, if the embolic material migrates, it may go directly into the main portal vein. Many unusual patterns of portal vein branching and variants also described and has to be considered for embolization planning. Embolization strategy is at least 1 cm safety distance in order to avoid reflux or migration of embolic material into left portal vein or main portal vein. For precise proximal embolization, the vascular plug or retrievable coil are reliable. For liquid embolic material, the proximal embolization is quite difficult to control and require operator experience. My routine techniques in case with conventional anatomy includes access from the right anterior branch, first embolization of the right posterior branch, subsequently select into right anterior branch and perform embolization. By separate embolization of each branch to avoid inadvertent embolization of embolic material into the main portal vein. Glue mixture preparation ratio is glue to lipiodol of 1:5 in order to ensure the peripheral embolization. Tract embolization can be done along with sheet removal when you perform ipsilateral approach, but when you perform contralateral approach, you have to be careful with tract embolization in order to prevent FLR vascular injury. The patient will be kept in the hospital at least 24 hours after the operation to observe the complication. In case with complex vascular anatomy or complex procedure, Catheter-directed CT portography or cone beam CT is very helpful. Here is the short video demonstration of the portal-vein embolization in patients with SCC, post-TACE, and plan for right hepatectomy. The initial FLR is about 29%. This patient has vascular variation, including accessory right hepatic vein, absence of right posterior portal vein with separate origin of segment 6 and segment 7. My mainstay embolic material is glue, but in this case, coil and PVA may be needed. The procedure starts with aseptic technique. The patient underwent mild conscious sedation. First, we perform grayscale ultrasound to see if there are any tumor in the needle path, and then we do color double ultrasound to check vascular patency and identify segment 5 branches. Then we perform local anesthesia with 2% xylocaine injection. I usually use micropuncture set, but sometimes I use spinal needle for puncture the portal vein. When the needle's tip is in the true lumen of portal vein, I could easily aspirate the blood from the needle. After that, I will check under fluoroscopy by injection small amount of contrast to see whether the needle position is good enough to insert the microguide wire. Then microguide wire was inserted under fluoroscopy into the main portal vein. After that, small skin incision was made and the micropuncture set was installed over the microguide wire. .035 guide wire was inserted into the micropuncture set under fluoroscopy. Then micropuncture set was removed. A 5 French introducer sheet was installed over the .035 guide wire. I usually kept the microguide wire as a safety guide wire. Sometimes if the introducer sheet is occluded or malpositioned, I can have another safety access route from the microguide wire. My routine catheter for ipsilateral approach is 5 French mod catheter from Merit Medical, which has narrow reverse curve. The curve has to be formed inside the patient. I usually form the curve with the side branch of main portal vein or around the splenic bifurcation. After that, I will perform flush portography by hand injection. The AP view is not the best view to demonstrate the portal vein bifurcation. Right anterior oblique can help you visualize the bifurcation between right and left portal vein. And then you can apply the cranial or chordate oblique to differentiate the branch of the right anterior and right posterior portal vein. You can control the reverse curve catheter without guide wire by using the maneuver of twist, push, and pull. Here is our first selective branch, the segment 7 branch. On the portography, we saw the abnormal vascular shunt suspicious to be connection with the accessory right hepatic vein. So in this case, I use the microcatheter to selective more distally. Selective portography identify the abnormal shunt, connect with the accessory right hepatic vein. We can tell from the course of the vessels and also the flow direction that run medially into the IVC. I decided to use core embolization for this branch because glue might penetrate the shunt into the IVC. After core embolization, the shunt disappears. Then we prepare glue for embolization the rest of segment 7 branch. When injection through 5 French catheter, I usually use the Log 5 ml syringe. Flush the catheter with 5% dewater before glue injection, and then inject the glue under fluoroscopy. When you satisfy with the proximal embolization, then you pull the catheter out. Beware the inadvertent embolization when you pull out the catheter. Then we insert a new catheter to select segment 6 branch. We use the guide wire to facilitate the selection. After that, segment 6 protogram was performed. Then glue embolization was done through 5 French catheter. Another catheter was used for main portography. Before the embolization of the last branch, I usually perform flash portography at main portal vein again to demonstrate the left portal vein, and then remove the safety guide wire. Select into the right anterior branch, which is the last branch to be embolized. Embolize with glue, and then gently remove the catheter along with the sheath and perform tract embolization with small amount of glue injection. In this case, we totally use 12 ml of glue mixture. There are 2 absolute contraindications for PVE. One is the overt portal hypertension, which is the contraindication for major hepatic resection. Another one is extensive tumor thrombus with portal flow obstruction. The initial hypertrophy response after PVE occurs within 21 days before reach the patho period. In patients with liver cirrhosis, the hypertrophy rate is lower. Sufficient hypertrophy can take more than 4 weeks, and repeat ICG retention tests should be done. The pre- and post-operative volumetric measurements are used to calculate hypertrophy rate and degree of hypertrophy. Variable factors that affect hypertrophy response are chronic liver disease, multiple sessions of chemotherapy, especially platinum-based chemotherapeutic agents, and diabetes. The major complications of PVE have been reported around 2.5% and mortality around 0.1%. The major concern is complications that preclude subsequent hepatic resection. For example, embolic material migration, non-target embolization, or proximal venous thrombosis. In patients with hepatocellular carcinoma, test has to be done before PVE in order to prevent tumor progression due to hepatic artery hypertrophy. Tests also reduce the arterial portal shunt and promote FLR hypertrophy better than PVE alone. Interval between test and PVE is around 2 to 4 weeks. Sequential test and PVE can turn initially unresectable patient to resectable. PVE can help surgeons to accomplish R0 resection in hilar cholangiocarcinoma. Prepared right dissectionectomy usually require right portal vein plus S4 branch embolization, and for left dissectionectomy, may require left portal vein and right anterior portal vein embolization. Embolization of S4 branch is technically challenging with the risk of embolic material reflux into S2 and S3. We usually perform S4 embolization first and then right portal vein embolization later. If the patient has several small branches of S4, it may be safer to embolize with PVA and coil. If the patient has jaundice and dilatation of bile duct in FLR, biliary drainage has to be done before PVE in order to promote FLR hypertrophy and prevent infection. After drainage, the total bilirubin level should be less than 5 before PVE. In colorectal liver metastasis with bilobar distribution, PVE can be part of two-stage hepatectomy. First stage is to control the tumor in left lobe, either by resection or RFA, then perform right portal vein embolization. If the FLR is adequate and no progression of tumor in left lobe, then the patient will undergo hepatic resection as a second stage right hepatectomy. This treatment paradigm can offer long-term survival benefit in patients who initially consider unresectable, but not all the patients with intention to treat has followed the step through the second stage. In conclusion, PVE is a safe and reliable method to induce FLR hypertrophy. PVE can facilitate curative hepatic resection in the patient who initially consider unresectable. The sequence of treatment and PVE strategy are different between HCC cholangiocarcinoma and colorectal liver metastasis. Thank you.
Thank you very much, Dr. Nacha. Very excellent presentation and very nice video and demonstration. I know, is there any question from the audience or from the panelists? If no, maybe I ask you a question. Do you think vascular plug is useful in PVE? Some operator actually quite suggest advocates plug-assisted portal vein embolization. Do you think it is useful?
Yes, the plug is very useful because you can control proximal embolization quite easy. But because in my institute we perform PVE before the plug era, so we have to find something else, and right now we kind of comfortable with glue. But nowadays, in case of the patient who has not enough FLR after PVE, we consider to do hepatic vein embolization in addition to PVE, and in that case, right now I use plug because in Thailand the plug cannot be reimbursed for most of the patients. So price is one consideration, and with glue is the cheapest embolic material to use for PVE. But plug is, right now I use for hepatic vein embolization. But plug is easy to use, I agree with you.
So in concerning the hepatic vein embolization, is plug alone enough, or you need a plug plus coil?
I use plug plus coil.
Okay.
Coil for the distal and then the plugs for the proximal.
Okay. There's one question from the audience. Any tips to avoid risk of glue tail when withdrawing the catheter?
Yeah, the glue tail. The tips is first is you try to not over embolize, which means the glue should not be touched with the tips of the catheter. When you have enough flow, the flow will flush the glue away from the tips of the catheter, and you should decide to stop the glue embolization before it's reached back to the tips. And then when you pull back, just a little bit, draw back the syringe just a little bit to keep negative pressure, and then pull it back. I think for glue embolization, it's safer to under embolize a little bit. It's more safer than over embolize. If you under embolize, you can using PVA or gel foam or large particle to finish the rest that glue did not cover. But when you over embolize with glue, it's quite a disaster and very hard to correct.
Okay, thank you very much, Dr. Nacha again. Yeah. Because of the interest of time, I think we have to finish our seminar here.
Yeah. Okay, I've been asked to close the session, but before that, can we invite all the panelists to turn on your camera? We take a picture again. And while we are doing that, I think it has been an excellent afternoon. So many good talks, and Dr. Nucha's video was excellent. She made glue embolization look so easy, but I assure you it is not so easy.
Yeah, it's quite disaster at the beginning, but I think 30 cases to make you feel comfortable with glue.
Yes. I also would like to thank the outreach committee of the PSCVIR chaired by Bien Su. I think they have, during this COVID period when we can't meet, they have put in so much effort to make sure we continue to engage the community. So thanks Bien Su and the committee for organizing this.
Thank you.
Yeah.
Thank you very much. Thank you.
Thank you, everyone.
Okay, we'll end the session here, I guess.
Thank you. Thank you. Bye-bye. Have a nice day.
Bye.
Thank you.
Thank you.
Bye-bye.
Bye-bye. Thank you, Dorothy. Thank you. Thank you, Ben Su.